Welcome dear PG aspirants. I am Dr. ANISH POORNA, Master Teacher in Ardent MDS. The topic that we are going to discuss today is an important one, osteomyelitis. So you can see from the term itself that it contains three parts, osteomyelitis. So from the name itself you can conclude that it is bone, marrow and inflammation. So what is the definition? You can arrive from the name itself that it is an infection arising from the marrow and it also involves the bone. Hence it is known as osteomyelitis. So you have to understand the definition of osteomyelitis before moving to the pathogenesis of osteomyelitis. So we all know from the name itself that it is an inflammatory condition. So first it arises at the medullary cavity. That is what the ideal definition of osteomyelitis says. So it begins from the medullary cavity and it then progresses. Where does it progress? It progresses slowly and extends to involve the surrounding or the adjacent periostea and the cortex. So it initially develops as an inflammatory condition due to infection of the bone marrow, and it extends to involve the periosteum and the surrounding cortical bone also. So what is the next structure adjacent to the cortical bone? It is the soft tissue. So the soft tissue also may be involved. So from the name itself it is very easy. You can easily remember the definition of osteomyelitis. It is an inflammatory condition that begins as a infection or inflammation of the bone marrow and extends and progresses to involve the adjacent periosteum. And what are the structures that it involves? Cortex, periosteum and also the soft tissues. So meanwhile it dissects all the structures of the bone. So what are the structures of importance that the osteomyelitis involves? It destroys the Haversian system mainly and also the Volkmann canals. So both the important structures of the bone are all involved in osteomyelitis. So what are the predisposing factors? We will study about the underlying pathology also, so that whenever you are asked a question in exam, you will know about the pathogenesis and also what are the various treatment modalities for osteomyelitis and what is the microbiology, everything regarding that. So first coming to the predisposing factors. Number one is host resistance. That is, whenever a patient is in immunocompromised status due to the consumption of steroids, uncontrolled diabetes, or he is having any type of blood cancer, or he is having under kidney transplantation, those conditions are also known as immunocompromised status. So whenever he is having any kind of immunocompromised status, next one it is factors affecting the bone vascularity. So this is a localized region. So whenever the bone vascularity is affected due to radiation or any bone malignancies or any conditions such as osteopetrosis, osteoporosis, Paget's disease, fibrous dysplasia or any kind of malignancy, the vascularity of the bone is disrupted. The architecture of the bone altered and that leads to the affected bone vascularity. Next one is the virulence of the organisms. This is an inflammatory condition caused due to infection. So we all know that. So some definite virulent organism is present due to that is the culprit for the causation of osteomyelitis. So the virulence of that organism is also the culprit for acts as a predisposing factor for osteomyelitis. So these are all the three important predisposing factors. One is concerning the host, one is concerning the local area, another one is concerning the organism. So next we will see about the etiology and pathogens. We all know that there is some virulent organism causing osteomyelitis. So what is that organism? It is mainly staphylococcal species. So they have found that the staphylococcal species is the main culprit for the causation of osteomyelitis. So what are the other causes? First one is the infection, as we all know. It can also spread through two routes. One is hematogenous spread. This hematogenous spread means it spreads through the blood route. This is very commonly seen in long bones. That is femur, tibia, anywhere it can come. In long bones, whenever it occurs, it is mainly due to hematogenous spread. So what is the way of spread in the mandible? It is the contagious spread. So due to contagion, it spreads from one part of the mandible and slowly distracts the other part and goes to the other side also. So that is the first reason. The second one is the trauma. The most common cause of osteomyelitis, secondly, next to infection is trauma. So next we will see why osteomyelitis is more commonly seen in maxilla, or not less commonly seen in maxilla and more commonly seen in mandible. That is why, because the mandible has only single supply and mandible has mainly cortical bone So these are all the reasons why mandible is most commonly affected in osteomyelitis. Most commonly affected in osteomyelitis. So mandible is the most commonly affected bone than maxilla in osteomyelitis, mainly because it has single blood supply, that is the inferior alveolar artery or its branches, and then it is mainly having cortical bone architecture. So what is the difference is the mandible has cortical bone, whereas the maxilla has more of spongy bone. That is, the cancellous bone in the maxilla is so much that the infection may get dissipated to the other areas, and there are also many collateral blood supplies in maxilla when compared to the mandible. So we all know that the occurrence is more commonly seen in mandible than maxilla. So we will come to the pathogenesis of osteomyelitis next. I am going to explain it in a schematic way. So first, what happens is, we all know the definition and we all know what is osteomyelitis. How it happens is, initially there occurs acute inflammation. So what happens after the acute inflammation? It begins in the medullary cavity. So what happens? The intramedullary pressure increases. So what happens after the intramedullary pressure increases? There is vascular collapse. Due to the increase in the intramedullary pressure, the blood supply in that particular area is affected. So it leads to ischemia. And what happens after ischemia? Due to abruption of the blood supply to that particular area, it goes for avascularity. The bone becomes avascular. Then it leads to osteomyelitis. So what happens in case of infection? Actually, the same thing as we saw earlier. Organism affects it. As we saw earlier, the two important components of bones are affected. What are they? The Haversian system and the Walkman canals. So the Haversian system is getting involved. What happens next? We all know it starts in the bone marrow and extends to involve the periosteum and the adjacent cortex also. Next, it causes elevation of the periosteum. Whenever the periosteum is getting elevated from the bone, what happens is there occurs blood supply disruption. Again, it leads to avascular bone, that is known as osteomyelitis. So this is the pathogenesis that happens in osteomyelitis. You can very well understand from the definition itself what are all the processes going on in the causation of osteomyelitis from the species of Staphylococcus organism. So next we will come about the microbiology, deal it in detail. So we all know that there is some virulent organism causing osteomyelitis. It is based on its virulence, host, and also the anatomical and structure factors. As we all know, it is more commonly seen in mandible than maxilla. And so what are all the recent studies they have done? Does only staphylococcal species cause osteomyelitis? No, they have also found that Streptococcus species, Peptostreptococcus, the Fusobacteria, Porphyromonas, Prevotella, and Echinella. These are all the other organisms apart from staph. So apart from staph, we have Streptococci, Peptostreptococcus, Fusobacteria, Porphyromonas, Prevotella, and Echinella corrodens. So these are all multibacterial. Actually, these many organisms have the potency or the virulence to cause osteomyelitis. So that is all about the microbiology. So we have already seen about the pathogenesis and what is the causative organism, the predisposing features and everything. Now we will go to classification. The classification was given by Lou and Wahlvogel. This is the classical definition of osteomyelitis, where he said it can be classified as one, suppurative osteomyelitis, where there is pus discharge and patient may have pain, and the second one is non-suppurative, where there is no pus involved. So this is sterile osteomyelitis. So here there will be pus discharge, and it can be classified again as suppurative, can be classified again as A, it is acute condition, and B, chronic, and third one is infantile, in infants. Whereas in non-suppurative, it can be classified as diffuse sclerosing, focal sclerosing, proliferative perostitis. You can know that this is another name for Gary's osteomyelitis. And the last one, that is osteoradionecrosis. That is a different chapter that we have discussed previously in the different session. If you want to know about it elaborately, you can visit that session. So this is the classification by Liu and Valvogel. We will come to see about the clinical features. So clinically, how is osteomyelitis is seen? One is it can be seen as an acute condition. Another one is seen as a chronic condition. Sometimes it can also be seen as an exacerbation or can be seen as a non-suppurative condition. Okay, so these are all the various clinical features of acute or clinical features of osteomyelitis. So first one we will see about the acute osteomyelitis. So what happens in acute osteomyelitis? The patient has deep and intense pain. The patient is having so much pain, he may have paresthesia. So what will you do? If you take up the blood investigations, all the levels will be increased. That is, the WBC count may be increased, the PMNs may be increased, the ESR is increased, and C-reactive protein, everything will be increased. That is pointing towards an acute condition. Whereas when you come to a chronic condition, all these features are exactly the opposite. That is, the patient will have a dull pain. It is not very intense as you see in acute osteomyelitis. You will have dull pain, and all these biochemical investigations or the blood investigations may be normal, or sometimes only the lymphocytes may be increased. Whereas in radiology, you can see the features of osteomyelitis. Whereas the radiology, the features of osteomyelitis you can't see in acute conditions. So in acute osteomyelitis, the radiological features of classical osteomyelitis may not be seen, whereas in chronic osteomyelitis, the blood investigations may be sometimes normal. So you can see the difference between acute and chronic osteomyelitis. Non-suppurative osteomyelitis, we have seen it may include chronic or focal diffuse sclerosing and Garrick's osteomyelitis. So these are all the clinical features of osteomyelitis. Next, we have understood the clinical features of osteomyelitis also. We will learn about the imaging. So we are having a provisional diagnosis of osteomyelitis when you see a patient. So what will you do? You have to look for radiological investigations. Clinically, the patient may also have sometimes fistula in a case of chronic osteomyelitis. So there are some differences between acute osteomyelitis and chronic osteomyelitis. We have seen that all the radiological features, sometimes the radiological features that we discuss here may not be present in acute osteomyelitis because there may not be sufficient bone resorption to be shown in the radiological features. So the patient may be having fistula in the case of chronic osteomyelitis. There may be sometimes pathological fracture also. All the features that we are going to see or discuss can be seen in a chronic osteomyelitis mainly. So first what will we do? We will take a simple radiograph such as occlusal radiograph or OPG. So these are all the simple tools that we have at hand to diagnose or what are the radiographic picture we want to see. We will go for simple x-rays like this. Next, what are the things that we can go? Remember again how osteomyelitis occurs. It occurs from the bone marrow. Bone marrow is what? It is a soft tissue. So initial stages of osteomyelitis, when you want to see, I told you in acute osteomyelitis, you cannot see the bone resorption. So what investigation will you do that time? It arises as inflammation of the or infection of the bone marrow. So definitely there is going to be some change in bone marrow even if it is acute. That time only if you take an MRI, that is it will show the changes in soft tissue, then you can identify if there is osteomyelitis. Whereas in chronic osteomyelitis you have to go for CT because there will be evident bone resorption. Another one thing is radionuclide imaging. We will discuss about that also, radionuclide imaging and its uses in osteomyelitis. So what are all the features that you can see in a radiography of osteomyelitis? It was described by Wirth. Three things he described. One is moth-eaten appearance, the second one is sequestra and involucrum formation, and another one is subperiosteal granular deposition. One is moth-eaten, the second one is sequestra plus involucrum, And last one is subperiosteal granular bone deposition. So these are all the features of radiology of osteomyelitis that were told. First one is moth-eaten appearance. That is, you can see an eaten appearance of resorption in radiology. Next one is sequestrum plus involucrum. What is sequestrum? Sequestrum is a dead bone. So what do you see radiologically? The radio opacity of the sequestrum is more than the radio opacity of a normal bone. So what is sequestrum? Sequestrum is dead bone. Sequestrum is dead bone and it is non-vital. So the dead non-vital bone is actually more radiopaque than the normal bone. Next one is the involucrum. What is involucrum? Involucrum is the attempt by the bone of forming new bone cells. So as there is sequestrum, there is already dead bone. So what is the body trying to do? It is trying to form a new bone. That is known as involucrum. Next one is subperiosteal granular bone deposition will also be seen. This is the radiographic picture of osteomyelitis. So next, as I told, we are going to see about radionuclide imaging. The advantage of radionuclide imaging is, as I said, it can be used for early detection of osteomyelitis as early as 3 days. So in those conditions, if you go for simple radiography like OPG or PA or occlusal radiography, you will definitely not see any radiological feature of osteomyelitis. At those times, you have to either go for MRI or radionuclide imaging because it is helping to identify osteomyelitis and arrive at a diagnosis as early as 3 days. So what do we do actually here? We use a material called technetium 99 modified with methylene diphosphate. So this is the material that we use, dye we use, and what do we use? We inject it IV and then we study it in 3 phases. So the 3 phases are important. One is flow study. The flow study is the first phase. Another one is blood pool phase. The blood pool phase is the second phase, and the third one is the delayed phase. So the flow phase occurs immediately, that is within 1 to 2 minutes. Next is the blood pool phase, where the blood is getting pooled and it takes some time, around 5 to 10 minutes. And last is the delayed phase, where it takes some hours, like 2 to 4 hours. So in each stage, how is the radiological picture? We will use it to identify osteomyelitis. We are not going to very in-depth. You have to definitely know about the 3 steps or these 3 stages and what is the material that we use for technetium 99 for radionuclide imaging. So how do we move on in this radiological investigation? So there is a definite algorithm or step-by-step process that we move on. So initially you are taking a normal radiograph. The patient is coming, you are having a doubt. Will that patient have osteomyelitis? You are having some doubt. So what will you do? In your college or any setup, you will take a definite radiograph. There is simple radiograph, that is OPG or PA. So you are taking a simple radiograph initially. If you have all the features of Wirth, that is, we discussed the 3 important radiological features given by Wirth for osteomyelitis. If you see any of these features, if you see sequestrum or involucrum or subperiosteal bone deposition, or if you see a moth-eaten appearance and you arrive at a diagnosis of osteomyelitis, you stop the investigation. Okay, if it is positive, you stop. If it is negative, but still you are suspicious of osteomyelitis, then what do? You go for technetium bone scan. What did you see? It is a radionuclide imaging using technetium 99 and methylene diphosphate. Next, you go for radionuclide imaging. Why? It helps to identify the lesion of osteomyelitis as early as 3 days. So if you have a result, you have the result and you see there is result of osteomyelitis. Though positive for osteomyelitis, you stop the result. So you no longer take further investigations. So if it is negative again and you have suspicion of osteomyelitis still, what do? You go for WBC scan. What is WBC scan is? It is using gallium. So again, if you get the result positive, you are getting positive for osteomyelitis, you stop it there. You do not take it forward. What do? If it is negative again, what we saw earlier, we take either CT or MRI. What do? If you suspect a bone marrow inflammation or infection, you go for MRI, and if it is CT, it will show the bone resorption. So if it is positive, it is osteomyelitis. If it is negative, even after that, it is definitely not osteomyelitis. So these are all the steps that you have at hand, or step by step or sequential manner in which you have to diagnose or move forward for osteomyelitis. So we will see about the types of osteomyelitis. Now we have seen that acute and chronic cases differ in the clinical representation. Acute has so much of pain, deep and intense in nature, whereas in chronic osteomyelitis there is only dull pain. Chronic osteomyelitis may have fracture and fistula also. So first one we will see how it is associated with fractures. Osteomyelitis plus fractures. So whenever osteomyelitis is present, we all know that it resorbs the bone. As a result, it will go for pathological fracture. So that is one kind of osteomyelitis. The next one is infantile osteomyelitis. It is nothing but the osteomyelitis that occurs in the children. Okay. The next one is diffuse, and fourth one is focal sclerosing. So these are all the other types. And the next most important one is proliferative perostitis. This proliferative perostitis is also known as Gary's osteomyelitis. Why? Because it was given by Gary and it is most commonly seen in children. It is a non-suppurative form of osteomyelitis, and what is the important feature is that you can see radiographically onion skin appearance. So this is an important feature. Onion skin appearance is seen in Gary's osteomyelitis. Another one important feature is they have found that in proliferative perostitis, sometimes it may be caused by staph species, especially staph epidermidis and staph aureus. So these are all the two organisms that are associated with proliferative perostitis. So we have all seen about the osteomyelitis in detail. Now we are going to see about another specific kind of osteomyelitis known as actinomycotic osteomyelitis. So what happens in actinomycotic osteomyelitis is, we all know actinomycosis is a gram-positive microaerophilic non-spore forming non-acid fast bacteria. So this is the most important thing you have to remember. Don't change it. It is a gram-positive microaerophilic bacteria. So that is, we all know the types of actinomycosis also. It can be cervicofacial, pelvic or abdominal also. So that is actinomycosis also causes osteomyelitis, that is known as actinomycotic osteomyelitis. Next we will see the tuberculosis osteomyelitis. The features are all same, the radiological features, everything may be same, but however the organism alone differs. So that is the importance of each and everything that we discuss here. So the tuberculous organism, that is the mycobacterium, can also cause osteomyelitis, and that is known as tuberculosis osteomyelitis. So what do we do here? We take an FNAC and we also go for AFB. So these are all the extra diagnostic methods that we use here for the diagnosis of tuberculosis osteomyelitis. So next one is organism is Nocardia. We all know Nocardia is almost similar to actinomycosis, and that is also causing osteomyelitis known as Nocardial Osteomyelitis. It is not very much important to discuss in detail because all the features are similar as we discussed earlier. The representation, the clinical presentation, the investigations are almost similar in all the cases of osteomyelitis. So next one is malignancy masquerading as osteomyelitis. So what is the importance of this is, we will not be able to differentiate sometimes between the malignancy and osteomyelitis. So malignancy sometimes may be equal to osteomyelitis radiographically. So radiographically and sometimes even clinically, malignancy may look like osteomyelitis. So they are asking you a question, how will you move forward now? So what will you do? In malignancy also sometimes the acute markers of inflammation may be increased, patient may be infected. So sometimes even the blood investigations may remain almost similar. So what will be the definite diagnosis? The radiography also is looking similar. So what you have to do is you will go for biopsy. When you do a biopsy, you will get a definite diagnosis whether it is a malignancy, it will show malignant features, whether it is an osteomyelitis, you will see necrosis and all that. So this is another feature of osteomyelitis. So next we are going to see about the treatment plan. So what is the treatment? How we are going to move forward? Now we have seen about everything about osteomyelitis, how it presents, what is the pathogenesis, what are all the various clinical types, what is the classification, how will you move forward with the step by step in investigation, what are all the clinical presentation, or what is the radiological feature, everything we have seen. Now we will discuss about the management. The first one is, first you have to initially, we all know about what are the predisposing factors of osteomyelitis. One is the host factors. Next one is the local factors, that is what are all the conditions that affect the jaw vascularity, that is the second one. Third one is the virulence of the organism. So these are all the three predisposing factors. So first we have to analyze these. First what will we do? We will analyze the host defects, whether the patient is immunocompromised or the patient is under steroids or the patient is under any transplantation. Everything we will analyze first. And then this is the first step, and then we will do gram staining and culture and sensitivity. So definitely we have to go for culture and sensitivity. Why? Because we saw earlier that Staphylococcus species is the most common species causing osteomyelitis. Apart from that, we have seen 5 different group of organisms that can cause osteomyelitis. So we should know what organism is causing osteomyelitis and what is the sensitivity, the drug that shows sensitivity to that organism. So we will do gram staining, culture and sensitivity next. Next we will do imaging. So what are the imaging techniques we saw? Radionuclide imaging also we saw. We will do imaging next, and then we will start with antibiotics. So these steps. The fifth one is, whenever the loose tooth is present or sequester. What is sequester? The more radio-opaque bone or the dead non-viable bone that you see in radiology, which is more radio-opaque than the normal bone, that is called the sequester. So you will remove that sequester. That procedure is known as sequestrectomy. When you remove the sequester, that is known as sequestrectomy. So you remove the loose tooth present there and also the sequestrectomy, because it will act as a focus of infection. Next, what will you do? You will, by the meantime, all these procedures you have done, by the meantime you will get the report of culture and sensitivity. So you will definitely come to know what is the sensitive drug for that particular organism. Now we will start with culture guided antibiotics. Previously we would have started on empirical antibiotics. Now we are moving forward to culture guided antibiotics. Next, we will go surgically, we will open up the lesion, we will irrigate well, debride, and then place any antibiotic locally. We will see about that later. And at last, if nothing is working out, we will go for sequestrectomy, debridement, decortication, and at last resection and reconstruction. So these are all the steps, surgical methods that we have for osteomyelitis at hand. So what is the antibiotic regimen? I told you earlier, initially we will start with empirical. And then we will move forward towards culture and sensitivity guided antibiotics. This is mainly to avoid resistance. And it will also improve the result of the antibiotics to the patient and improve him physically also. So first we will go for penicillin. The drug of choice is penicillin, aqueous penicillin. Will give IV along with metronidazole. Metronidazole 500 mg IV, again IV. Okay, next to the drug of choice is clindamycin. You can also go for clindamycin. Apart from this, another drug you have is moxiclav, that is amoxicillin plus clavulanic acid. So these are all the drugs or antibiotics that you have at hand for treatment of osteomyelitis. Suppose the patient is at hospital, you will give IV drugs. Suppose the patient is at home or his daycare center, you have to give oral drugs. So these are some of the antibiotics that you use in osteomyelitis, be it actinomycotic, nocardial or tuberculosis osteomyelitis. Whenever the patient is having tuberculosis osteomyelitis, you will follow the same anti-tuberculosis regimen as HRZT. The same regimen that you follow for tuberculosis, you will follow for tuberculosis osteomyelitis also. So as I told you earlier, these are all the antibiotic impregnated beads. So why we are giving antibiotic beads here is because the local drug effect, the effect of the local drug acting here will be increased. These beads are made up of vancomycin or linezolid. So you will give this antibiotic impregnated beads, you will open up the area, you will debride it thoroughly and keep the antibiotic beads so that over a prolonged amount of time the antibiotic efficacy will be present in a localized area rather than systemically. So this is the procedure that I was talking about, the sequestrectomy. You can see the sequestrum here. In CT, you can very well appreciate it. So the process of removing the sequestrum, that is the dead non-viable bone, is known as sequestrectomy. So this is the sequestrum that we have removed. This is the procedure of sequestrectomy. So next, the procedure is known as sorcerization. This is another surgical procedure that we have at hand for osteomyelitis. This is a classical picture for osteomyelitis. So if they ask you this picture, so you have to immediately click on sorcerization. So this is the saucer-shaped defect. From the name itself, we can understand that we are creating a saucer-shaped defect. Why are we creating that? Because we are exposing the medullary part also, and so that we can keep a medicated pack over there. Initially, the sequestrum will be present over that area. Whatever antibiotics you give, it is very difficult to penetrate the sequestrum. So what you should do, you should remove the sequestra and expose the medullary area and also place a medicated pad there. Then the patient will get all the antibiotics and the dead bone is also removed, and now the patient will have good results. That is known as sorcerization. As you are producing a saucer-shaped defect. This procedure is known as decortication. From the name again you can understand. What did we learn about osteomyelitis definition? It is very important because, again and again I am emphasizing on it because from the name itself you can understand so many things. So the osteomyelitis begins as an infection of the bone marrow and it extends to involve the cortex also. So whenever the cortex is involved and a sequestrum is present there, you have to debride and remove the cortex also. That is what you are doing here. The complete cortex you are taking off. So that is known as decortication. So what is the last step? Because you have to go for resection whenever something is not working out. You have tried all the means, that is decortication, sorcerization, debridement, you have tried everything. As suppose you are giving antibiotics also through IV, nothing is working out. At last, the best treatment option that you have at hand is resection and reconstruction. You are resecting the whole osteomyelitic area and you are also giving reconstruction. So this is the last resort that you have for osteomyelitis. Another one important topic of discussion is hyperbaric oxygen therapy. We have seen that in detail about the physiology and how it works in the osteoradionecrosis session. If you wish to see about that, kindly visit that video also. So this is all about osteomyelitis. I think we have discussed in detail about the definition, the clinical features, the classification, how it presents clinically and how we move forward with the investigations, what are all the blood investigations we do, what are all the radiological investigations we do, and updated things about the antibiotics and what are all the various organisms producing osteomyelitis and what are all the treatment options we have with beautiful pictures. So whatever the questions you get based on osteomyelitis, I think you will be very sure to answer those questions. So have a happy learning and a thorough concept-oriented learning. Thank you.